Hello. We're going to talk about the child with cardiovascular dysfunction this evening, and let's go on and get with it. There's two types of cardiac defects. The congenital defects usually result in anatomic abnormalities that result in abnormal function of the heart. Then we have acquired defects as well. And these are usually related to a disease process like infection or autoimmune responses, which have the effect of the inflammatory system attacking the heart muscle and affecting the heart function. With environmental factors, they can play into dysfunction as well as family tendencies. Some of the history that we might see with a child who has a cardiac defect or a cardiac dysfunction is that symptoms may not appear until 4 to 12 weeks after birth. If you think about this, this is when the circulatory system is finally stabilizing after the birth process. So that's why we start seeing these symptoms later on rather than right after birth. We might see a child who has failure to thrive, poor weight gain, or activity intolerance. We may see developmental delays. When we look in the pregnancy history, we may see a positive factor for cardiac defects may be seen on an ultrasound during the prenatal period. We may see that there's a family history of cardiac disease. Whenever there's a family history of cardiac defects, we often will see it repeat generation after generation. Chromosomal abnormalities often have more than one problem associated with them. So, for instance, with Down syndrome, we also have heart defects that are associated with it, although we tend to think about the mental disabilities and the facial features and muscle tone issues that go with those. We often find that kids with cardiac dysfunction will report having frequent infections, and premature babies have their own set of problems that are associated with being premature, like their PDA not closing or their foramen ovale staying open. Those parts of the heart were supposed to still be open, and so now that they're outside of mom and those are supposed to close, the problem is they're immature, and so it's more difficult for those areas to close up like they're supposed to. Some of the physical indicators of cardiac dysfunction when we do a assessment is we'll see poor feeding. Now, think about the fact that with poor feeding, if it's happening for very long, you're going to have decreased weight gain and failure to thrive. So you can see how history and assessment goes together. We often will see tachypnea and tachycardia. If you think about it, we have a heart function that's not getting enough blood circulating throughout the body because maybe the muscle has been damaged or there's a shunting going on so that we're not getting good oxygenated blood out to the rest of the body. And so with that, our body is going to sense that hypoxia and is going to say, well, maybe if we breathe faster, we're going to be able to get that oxygen level up. Unfortunately, with the heart defect involved, we don't get increased oxygenation, even though we have the tachypnea happening. And then, of course, if we're not having a strong enough stroke volume going out to the body so that the blood pressure isn't being raised, the body will respond by increasing the heart rate, which is how we end up with the tachycardia. Diaphoresis is common. Crackles in the lungs and hepatomegaly are kind of related in that the crackles that we're hearing in the lungs are related to the lungs becoming waterlogged because of the congestive heart failure that's taking place. What's interesting with the hepatomegaly is that in infants and young children, you can often feel the lower edge of the liver of a normal child without any kind of defects just below the right costal margin. It's often normal in a newborn to be able to feel that liver at 1 to 2 centimeters below that right costal margin. As they get older, the liver starts moving up so that it falls up and under that costal margin, and then we don't feel it, except as people head into congestive heart failure, the liver starts becoming enlarged. And so when we have that happening in an infant or a small child, we can often find that edge of the liver to be 3, 4, even 5 centimeters below that right costal margin. Cyanosis is often associated with heart defects as well as murmurs. So let's talk about murmurs. One of the things that we want to do when we hear a murmur is to note the location. Where are you hearing it on the chest? Are you hearing it at midline, at the fourth intercostal space? Are you hearing it at the sternal border? Where are you hearing it? So we have to note that. That's something that we chart in our documentation. Also, we have to talk about the relation of the murmur to the heart cycle and how long it lasts. So what we're talking about here is, am I hearing this murmur in systole or am I hearing it in diastole? And is it just during those brief moments of the heart cycle, or are they running through the entire heart cycle? And that's what we mean by duration. Intensity is graded, and it is the level of noise that the turbulence of that blood flow is causing. So a grade 1 murmur is very, very soft, and most novice nurses have difficulty hearing them. And even some of the more experienced nurses will often be unsure as far as, did I hear a breath sound or did I hear a murmur? And it was not uncommon for me as an NNP to be called to the bedside of somebody who said, I think I heard a murmur, but I'm not sure. And I would listen, and sure enough, they had heard a grade 1 murmur. A grade 2 murmur is also soft, but it's easily heard. These were the ones where the nurses would say, I definitely heard a murmur. I would call it a grade 2. And a grade 3 is loud without thrill. So you might say, well, what's a thrill? Well, a thrill is when you can feel that turbulence of the murmur as if you touch the chest. A grade 4 is loud with a precordial thrill. A grade 5 is loud and is audible with a stethoscope. And a grade 6 is very loud, and you can often hear it without the stethoscope actually being on the chest. And actually, even with a grade 5, sometimes you don't actually need the stethoscope to hear it. But you can often hear a grade 6 just with your naked ear without a stethoscope. Then we want to also talk about the quality of the murmur. Is it a very harsh sounding murmur, like a washing machine with the clothes moving in it? Does it have a mechanical sound to it? And these are all words that we use to describe it. Or is it musical, meaning it's more high-pitched? And that's when we start saying it's high-pitched, it's medium-pitched, or it's low-pitched. And then, is there a variation of the murmur depending on the position that the child is in? Does it go away when they sit up, or does it become louder when they sit up? When they lie down, does it disappear, or does it continue? Does it get louder? Does it, what happens to it? So this is the sound that you would hear if you heard a murmur. And I wanted you to be able to hear that because it really is this rather swishing sound that matches with the systole and the diastole, the lub and the dub in your heart tones. Some of the other physical indicators of cardiac dysfunction include edema, clubbing of the fingers, fever, and actually you can have clubbing of the toes as well, having fevers, having retractions. The retractions go along with that tachypnea. You may see a prominence of the precordial chest wall. So you might actually see pulsations on the chest wall over the heart. You may see abdominal distension. That abdominal distension is often related to the hepatomegaly, and in some cases they may actually have hepatosplenomegaly. You may see visual, engorged, or abnormal pulsations in the carotid veins and arteries. You may see engorged vessels in the neck, or may see those pulsations, like I said, in the chest wall, or you may actually see the pulsation of their carotid arteries. So here's our first question. The nurse is assessing a child for cardiac disorders and documents the presence of clubbing of the fingers and toes. Which of the following conditions might this indicate? Infection, cyanosis, edema, or hypoxia? So I want you to take this question apart, because would we see clubbing of the fingers with infection? Well, probably not. Would we see clubbing of the fingers and toes with cyanosis? Well, those two often go together, but cyanosis and edema are really symptoms of another problem. Edema may be related to heart function, and so we may not be bringing the blood back out of the lower extremities, and so they have edema of the lower extremities. However, hypoxia is what causes clubbing. Hypoxia is what causes cyanosis. And so the correct answer on this is hypoxia. Clubbing usually doesn't appear until after a year of age, and it implies chronic hypoxia due to severe congenital heart disease or a lung disorder. The sign of infection is fever. Cyanosis is that bluish tint that's due to decreased oxygenation, and edema is swelling or bloating due to fluid imbalance. I want you to notice the hand on this person who has clubbing, and you can see how the area around the distal areas of the fingers are enlarged. And then we also have this thing called Shamroth sign. And if you look at the first picture, it would be like you took your index fingers and put them together. And so if you put your first knuckle above your fingernail, side by side of both your right and your left fingers, you can see that, yeah, you might have this little space, which they call Schumacher's window, but this is normal. However, somebody who has clubbing, when they put their fingers together, the clubbing will actually cause their fingers to curve away from each other, and there won't be this Shamroth's window sign there. I wanted to show you a little bit about an echocardiogram, and hopefully this is going to work for us. And I also want you to notice during this video that there is a place where in the background you can see the screen for the echocardiogram, and you'll see blue and red colors, and that actually is demonstrating the flow of the oxygenated, the red blood, and blue is the deoxygenated blood. So if a child was to have a VSD, a ventricular septal defect, you would see a blending of that red and blue blood crossing that defect in the heart. But I'm going to be quiet now and let you watch this short little video.
Hello, and I'm Rui. I'm here to get an echo scan. Okay, Rui, I'm going to do a scan of your heart today. So could you put your t-shirt off? Would you alright? Now what I'm going to do is put some jelly on and some sticky buttons and we're going to get some nice pictures of your heart. Okay? So we've got 3 little buttons. So we can see all your heartbeats on the screen. But they're not very sticky.
Why do I need an echo scan?
Because doctors asked us to have a little look inside your heart and check everything's connected properly, and we're going to check to see how well your heart's beating.
Okay. How long will it take?
It will take about 10, maybe 20 minutes to get all your pictures. Sometimes it may take a bit longer if your pictures are a bit more difficult to get.
Okay.
So could you roll over onto your left side, over to these sides? Perfect. Now this arm, go up by your head. Alright, super.
Will it hurt?
It won't be sore, it'll be a little bit cold with the jelly, and it might be a bit tickly. If you look at this screen, you'll be able to see some pictures of your heart. Alright. How do you think that sounds like? My heart. Now for another few pictures, and we've got some jelly at the top. So if you can lie onto your back, alright? So facing up the way, just how you started. Well done. And just straighten up for me, alright? We'll get all that jelly off your arm. If you pop your arm down for me, good. A little neck picture first of all. If you tilt your head, you look at the wall behind, is that alright? Super. That's great, well done. Now we're going to have a little look from your tummy and look at your heart from underneath. Is that alright? Not too sore? Okay, that's me finished. Well done. What we'll procedure, get some tissue. I think I'm strawberry jelly now. Covered in jelly. I'll get some tissue, I'll wipe it all off. Okay. And I'll take your sticky badges off. Okay, Rudy, how was that?
It was quite tickly.
Sorry about that. Okay, do you want to sit up? We'll get your top back on.
So obviously this was made in Glasgow, so they have quite the little accent there, but the procedure is the same whether it's done in England or in Texas or in Australia or Japan. Basically, that's how an echocardiogram is done. And like she said, it normally will take about 10 to 20 minutes, depending on how easily or difficult it is to get the pictures. And so there really isn't any prep that needs to be done for it. With an older child, you want to explain to them what's happening, but with a baby, usually we just kind of help them position. And often the echocardiogram techs are usually so good at doing these because they do them so often that usually they don't even need help getting them done. Another procedure that's often done, it can be done for diagnostic purposes, but it can also be done as an intervention, is cardiac catheterization. Now, this is a little more difficult, and depending on the age, and if you notice in these examples of when we do this interventional cardiac cath procedure, we're looking at things that are going to be found during the neonatal period. Things like pulmonary artery stenosis, transposition of the great vessels, an arterial septal defect, and some of the complex single ventricle defects like left hypoplastic heart. So what they do with infants is they will use the umbilical vessels. So as we pointed out in the videos that I asked you to watch, we have 3 vessels in the umbilical cord, 2 arteries and a vein. The arteries always look really tight and small. They're kind of like the eyes with it, and then the vein is a much larger vessel because it doesn't constrict, and so it looks like looks like 2 squinty eyes with the mouth wide open, like, oh my! So those are what the vessels look like. So what they would do is to catheterize the vein in the umbilical cord, and that will take them right up to the atrium. And then what they're able to do is to cross over the atrium from the right side to the left side through the foramen ovale. When they get to the opposite side, to the left side, they blow up this balloon. And with blowing up that balloon, they now yank it. And when I say yank it, I mean they put some good pressure on it. And they pull it across that foramen ovale and make a bigger hole where this smaller hole was at one time. And you might say, well, why are we doing that? Well, in these cases, the transposition, the complex single ventricle defects, you need blood mixing until they can do a repair on this child. And we don't want the ductus arteriosus to close up. And so in order for this child to grow and get a little bit bigger, we need that mixing to take place at the level of the atrium. So that's what we're getting accomplished by making this hole in the heart much bigger. Then what they'll do when they go in to do the heart repair, they'll repair that enlarged hole as well when they go in to do the heart surgery. And this picture kind of shows, in this particular case, they're going into the pulmonary valve and stretching the pulmonary valve with that balloon. So question number 1. After the child returns from cardiac catheterization, the nurse monitors the child's vital signs. For how many seconds should the heart rate be counted? 10, 15, 30, or 60? Well, whenever we think that there may be a cardiac defect, or whenever we think, or a cardiac dysrhythmia or a cardiac problem, we always make sure that we listen for a full minute, whether this is an adult or whether this is a child. Not to mention that, say we are giving this child or adult digoxin, that's another drug that affects the contractility of the heart, and so we're going to listen to that heart rate for a full minute as well. And so always when there is cardiac medications or cardiac problems, we're going to listen to the heart for a full minute. Now, as you know, we are able, with some of our vital signs, to listen for 15 seconds and multiply it times 4. And if you have a very regular heartbeat, you're going to get the same heart rate whether you listen for 15 seconds or listen for a full minute. But on a cardiac patient, you are going to listen for a full minute. When we look at cardiac catheter procedure care, the pre-procedural care is to prepare the child and the family for the procedure. Like I said, the ones that we mentioned are normally done, the interventional catheters are done during the neonatal period, just after birth, but children with cardiac defects may need to have cardiac caths done when they get older. So you want to prepare them for what's going to happen, that they're going to they're going to sedate them, and when they wake up, they're going to have pressure and weights over the area where they inserted the catheter, usually in the femoral vein. And so with that, you want to make sure that they understand that that's what's going on with it. Also, you want to use developmentally appropriate materials to explain the procedure to the child. So you may want to have a doll that is already prepared in the department that's going to show how they do the procedure, that they're going to have this little spot in their groin area. You want to assess and mark the pulses, so that they're easy to find after the child is sedated. You need a baseline O2 saturation, and usually the child is NPO for at least 4 to 6 hours before the procedure is done. Post-procedurally, you're going to check the pulses distal to the site. So in other words, if we've gone into the femoral artery, we're going to be checking pulses down in the popliteal area or in the feet. We want to monitor the temperature and the color of the extremities. We're going to take vital signs every 15 minutes. We're going to monitor blood pressure. We're going to monitor the dressing for excessive bleeding or if a hematoma is forming. Ideally, we should not have a hematoma because we try to get pressure on that site immediately after the catheter is pulled. We're going to monitor INO because we will have put dye in, and the dye may be affecting kidney function. And so we want to make sure that this child has normal output, that their kidneys are working. Also, we're going to monitor their blood glucose levels. Some of the focus of the nursing care for children with cardiac disorders include improving their oxygenation, promoting adequate nutrition. Often these kids need to have higher calories because of the energy that's being expended in the body trying to compensate for their low cardiac output. We want to assist the child and the family with coping and provide postoperative nursing care, as well as preventing infection and providing the child and family with education. So when we teach them about the different medications, and often these kids are on several different medications, we want to make sure that the child and the family know, what does the medicine do? If we're giving digoxin, we know that it's going to increase the contractility of the heart so that they have a stronger cardiac output. More blood is being pushed out to the rest of the body. But we also have to remember that if they're receiving digoxin, that they may have decreased heart rate, and we have to watch for that. How and when should I give the medicine to my child? Is this a once a day medicine, or is this a several times a day medication? Does it need to be taken with meals, or does it need to be taken on an empty stomach? What should I do if my child misses a dose? Do we double up? Do we only give just the regular dose? With digoxin, we would only give the regular dose. What should I do? What precautions or special instructions do I need to know, like feeding issues? Is it compatible with other medications that they're on? So in other words, can I give them all their medications at one time, or do I need to space them out because of the interaction of the drugs? Are there any activity restrictions associated with the medications? And what are the common side effects? And what kinds of things do you need to do when giving this medication? Because just as we check the heart rate before we give a dose of digoxin, so do the parents check the heart rate before they give their dose of digoxin. What are some of the psychosocial interventions? Well, we want to explain all that is happening to the child using language that both the parents and the child can understand. We want to allow the parents and the child to voice their feelings, their concerns, or their questions. It may be appropriate to separate the parents and the child so that the child is not unduly concerned if the parents are uncomfortable expressing those concerns in front of the child. You want to provide ample time to address the questions and concerns. So in other words, you're not standing at the bedside waiting to get out the door. You need to have enough time that you're able to sit down and take your time and allow the parents to digest the information that's being given to them. You want to encourage the parents and the child as developmentally appropriate to participate in the child's care. So if they've had surgery, then if it's appropriate, we might teach the child some of the things that need to be done with their dressing changes or their wound care, because that's their body and they take care of every other part of their body. They need to be able to take care of their wound as well. Nutritionally adequate nutrition is critical to foster growth and development for children with cardiovascular disorders, as well as to reduce the risk of infection. Congenital heart defects typically have increased nutritional needs because of the increased energy expenditure associated with increased cardiac and respiratory workloads. Your heart is having to work harder because it's not beating as effectively, but the body is still demanding that output. And the respiratory system is also having to work harder, and that causes the child to burn more calories. Nutrition is provided for children with cardiac disorders orally, ideally. They may have to have NG tube feedings overnight in order to have adequate amounts of calories in a 24-hour period, or they may need to have parenteral nutrition if they're not taking in enough orally or enterally. Congenital heart disease has an incidence of 5 to 8 per 1,000 live births, so it's fairly common. 2 or 3 of those infants are symptomatic in the first year of life. Congenital heart disease is the major cause of death during the first year of life, not including prematurity. Most common anomaly is the ventricular septal defect. And in 28% of kids with congenital heart disease, usually there's another recognized anomaly also present. And so let's go back to the whole idea that chromosomal abnormalities often have more than just one anomaly associated with it. Some of the causes of congenital heart disease is chromosomal or genetic causes in about 10 to 12% of them. Maternal or environmental causes are in about 1 to 2%. These include maternal drug use, or like, for instance, children that are born with fetal alcohol syndrome. About half of those have congenital heart disease. If there's maternal illness like rubella in the first 7 weeks of pregnancy, it's associated with a 50% risk of defects including PDA and pulmonary branch stenosis. Cytomegalovirus, toxoplasmosis, and other viral diseases, obviously they often lead to cardiac defects depending on when they occur during the pregnancy. Also, infants of diabetic mothers have a 10% risk of congenital heart defects, usually ventricular septal defects, cardiomyopathy, which means that the heart muscle is enlarged, and transposition of great arteries are the most common in children of infants of mothers with diabetes. And then multifactorial problems are 85% of the children with congenital heart defects. So I had you watch some videos about fetal circulation and the development of the heart. And so one of the things that I wanted you to understand is that there are normal fetal circulation changes that happened at birth. And so on the left side of the screen, you'll notice that the blood that's circulating through the heart comes in as blue blood, in other words, deoxygenated blood into that right atrium, except for that oxygenated blood that's coming from the placenta. And it, at that point, the blood mixes. And so we've got this sort of pinkish, purplish colored blood that's circulating in a fetus. That's why when babies are born, they're not immediately pink. They usually look pretty cyanotic when they're first born. Also, you'll notice that the foramen ovale is open because the blood does not need to go to the lungs at the levels that it does after the child is born. And that also we have the patent ductus arteriosus as well. So when that newborn takes that first breath, the fetal vascular system undergoes these very rapid changes. The umbilical vein and the umbilical arteries close. So before birth, the vein delivers oxygen and nutrients to the fetus, and afterwards, the vessels fill with fibrin and clot off. Then the foramen ovale closes as pressure in the left atrium exceeds the pressure in the right atrium. So in other words, those two layers of tissue that have been open up to this point, the one closes over that hole, and from that point on, it's closed. With the ductus arteriosus, it starts to close in the presence of increased oxygen. So what that means is if I have a child who has a ductal dependent cardiac anomaly, I need to keep that PDA open. And so we don't give them any extra oxygen. We keep their oxygen levels low because the oxygen is going to close that PDA. Not only that, but we're going to give them medication that keeps it open. So, but when we're talking about the normal changes, we want all of these things to happen. We want that ductus arteriosus to close, and as you remember in that video, it takes a while for that ductus to completely close down. And it takes, the foramen ovale, it closes pretty quick. But the umbilical vein and the umbilical arteries, it takes a while for that fibrin to form and for them to turn, both the vein, the arteries, and the ductus arteriosus turn into ligaments after they've become filled with fibrin and they're all closed down. I wanted to mention persistent pulmonary hypertension at this point. I don't believe it's actually in your book, but it's a very serious respiratory / heart defect. And it occurs when the newborn circulation does not transition normally after birth. So in other words, the ductus arteriosus stays wide open. The foramen ovale doesn't close, so we have continuous mixing. Not only that, but we have other things going on. We'll talk a little bit about the pathophysiology on that. Some of the causes of PPHN is what we call it, persistent pulmonary hypertension, is we just don't know. It just happens and we're not sure why it happened. It just did. Hypothermia can cause acidosis, and with acidosis, these the lungs continue to be high pressure, and so you don't get good blood flow into them, and hypoxia results with that. So the patent ductus arteriosus stays open, so that's some of the things that can go on with that. Perinatal asphyxia can happen. Meconium, with meconium aspiration syndrome, we already have a problem in the lungs because of the meconium that's in there. Maternal smoking, there's some thoughts about how that affects the lungs and that transition to newborn circulation. Maternal obesity, hypocalcemia, maternal asthma. If you think about asthma is often passed from one generation to the other. The mother has lungs that are very sensitive to stimuli. The child could as well. If the child has pneumonia, if they have congenital heart defects, or if there's metabolic disorders. So the pathophysiology is that the pulmonary pressures remain increased. And as a result, the child develops hypoxemia and acidosis. This results in vasoconstrictions of the pulmonary arteries because they like oxygen, and the oxygen causes the pulmonary artery to relax. And so without that, with the hypoxemia and acidosis, they constrict. Also, with the acidosis and hypoxemia, the ductus arteriosus and the foramen ovale stay open. And so what we get is right to left shunting, which means that we're not getting we get very little oxygenated blood out of the lungs. The symptoms initially are tachypnea that turns to marked cyanosis, grunting, respiratory distress. A murmur is present because of the PDA and the foraminal valley being open, and the child becomes hypotensive related to the acidosis. And over time, you can also see polycythemia developing because of hypoxia. So the nursing management is to make sure at birth that they have immediate resuscitation, that they stay nice and warm and cozy, that they get a hat on their heads because most of their heat is lost through their head because their heads are so big in comparison to the rest of their body. We're going to monitor their oxygen saturations closely. We're going to cluster their cares because we don't want these kids to get upset. Because when they get upset, it causes more constriction of the pulmonary vessels. We are going to monitor their blood gases frequently, monitoring their vital signs closely. An echocardiogram is going to be done to verify the diagnosis. And we're going to correct the acidosis and the hypotension with fluid boluses, usually normal saline. We may give sodium bicarbonate, but we usually don't give the sodium bicarbonate until we've given the fluid boluses. And we're also going to give them vasopressors, but as you recall with vasopressors, if you don't have any volume to push around, it doesn't do any good to make the heart have to work harder. So obviously, first the fluid boluses, then the vasopressors and the sodium bicarbonate. These kids definitely need respiratory support, and they often are put on high-frequency ventilation, and nitric oxide is often very effective in helping the pulmonary vasculature to relax and improve ventilation and increase oxygenation, which improves both the acidemia and the hypoxemia. If that doesn't work, these kids go on ECMO. ECMO is a form of bypass where we oxygenate their blood outside of the body so that we can allow time for their lungs to relax and be able to do their work. Often kids who have pneumonia or meconium aspiration end up on ECMO. One of the things to remember about ECMO, though, which stands for extracorporeal membrane oxygenation, which means oxygenation through a membrane outside of the body, is that in order to go on ECMO, you are at a point where there's a good chance you're going to die. And of the children that go on ECMO, only about half of them live. So when kids go on to ECMO, you're talking about a seriously ill child who now has around a 5 to 25% chance of living and surviving past ECMO. They're also not sure because they cannulate the carotid artery on one side. They're not sure whether that will increase the risk of stroke in children that have been on ECMO later on in their life. Most of the early ECMO children are now in their teen years, And so it will be interesting as they age even further to see if there's an increased risk of stroke in these children. Basically, this slide shows sort of what's going on with these kids. We keep actually 2 pulse oximeters on them, one on the right hand, on the right wrist, because as you remember the circulation of the heart, the first vessels that come off of the heart goes to the head and the right side of the body. The second and third vessels that go off go to the left side, and then of course the aorta goes on out to the body. So the highest oxygenation is going to be in that right side of the body, the right upper part of the body. And so we monitor oxygenation there, but we also monitor oxygenation at the lower side. So what we're seeing is the results of the shunting that's taking place in that lower oxygenation. Also, we're going to make sure that there is no stimulation for this kid at all. They are put in a room all by their lonesome, and we close the door. We cover their eyes, whether they need to be covered because of bilirubin or not. We cover up their eyes, and we put ear muffs on them so that the sounds that they're hearing are very minimal, and they aren't seeing anything to overstimulate them. We also usually they have lines in, usually umbilical lines, and they are intubated. We often will try to give them surfactant if that is something that's appropriate for them to improve their oxygenation, to get the lungs to open up. We may use it with meconium aspiration children as a way to help wash out that meconium that's down in the lungs. The meconium also causes the surfactant, the natural surfactant, not to be produced because of the inflammatory reaction that's going on there. So the artificial surfactant helps with that as well. And we're going to be doing, like I said, lots of blood gases and possibly nitric oxide and even possibly ECMO. So congenital heart defects, it's kind of interesting because your book talks about 2 different ways of looking at heart defects. One is to look at them as far as cyanotic heart defects and acyanotic heart defects. A child that has a cyanotic defect is in a situation that, because of the shunting that's going on in their heart, no matter how much oxygen I give them, I am not going to be able to increase their oxygen saturation, and they're going to be cyanotic no matter what. And so if you look on this list, the ones that are highlighted are the ones that I've asked you to do especially good study on them, which include tetralogy of Fallot, transposition of the great artery, and a hypoplastic left heart syndrome. Acyanotic heart defects do get improvement with supplemental oxygen, and so we do give them more oxygen. And these include things like ventricular septal defects, atrial septal defects, atrioventricular septal defects, which are known as Cushing defects, patent ductus arteriosus, and coarctation of the aorta are the ones that I've asked you to know about because these are the more common defects. The other ones are really interesting too, but I want you to focus on things that you're more likely to see and more likely to get questions about on boards and in your ATI exams. Another way of looking at them is the hemodynamic characteristics of the defects. And your book actually talks about how this is something that we are starting to look at this more in our descriptions rather than the cyanotic, acyanotic. But I can tell you that nurses are still referring to heart defects as cyanotic and acyanotic. So disorders that have decreased pulmonary blood flow are things like tetralogy of flow. So if you have decreased pulmonary blood flow, that means you're going to have decreased oxygenation and you're going to be blue. Disorders that have increased pulmonary blood flow include a patent ductus arteriosus because it crosses over and bypasses the pulmonary flow, but yet at the same time it will back up, and so you end up with increased flow. Atrial septal defects and ventricular septal defects. That moving of the blood back and forth across those defects are what increases the pulmonary blood flow. So in other words, on them, you're getting a left to right flow instead of a right to left flow. Obstructive disorders include coarctation of the aorta, which is one that I told you to know about, aortic stenosis and pulmonary stenosis. In other words, you have narrowing of those vessels, and that means that the heart has to work harder to push the blood past those obstructions. Mixed disorders include transposition of the great arteries, which means that you've got, and we're going to talk about this a little more, but instead of having the aorta coming off of the left side of the heart, you have the pulmonary artery coming off of the left side of the heart. And instead of the pulmonary artery taking blood to the it's still taking blood to the lungs, but it's coming off of the left side instead of the right side. And so it's just recirculating this oxygenated blood. And the aorta is coming off of the right side of the heart, so it never got oxygenated. And so it becomes a problem. Total anomalous pulmonary venous return, truncus arteriosus. The truncus happens when the heart does not fully develop. And so you still have more of a tube type formation of the heart instead of atria and ventricles like you see in a mature heart. And then hypoplastic left heart syndrome. And this little one up above has had heart surgery, and you can see his little scar on his chest. So the increased pulmonary blood flow defects, we have an abnormal connection between the two sides of the heart, either at the septum or the great vessels. And the increased blood volume on the right side of the heart and increased pulmonary blood flow, which leads to decreased systemic blood flow. And that's why they tend to have some cyanosis, because of that decreased systemic blood flow, but we can improve that cyanosis by giving oxygen to them. When we have increased pulmonary blood flow with an atrioventricular canal defect, this is commonly seen with Down syndrome. And what happens if you look at this picture is you can see where the valves should be on the right side, especially it tends to be more severe on the right side. And what happens is they don't develop the endocardial cushions, which are the separations between the atria and the ventricles. And so there is mixing going on there. And also because they're not getting that cushion across the middle of the heart, they also have the ventricular defect as well. So we've got a left to right flow, and so we have mixed blood going up into the lungs, and then oxygenated blood returning to the left side of the heart, only to go right back over to the right side again. So you can understand how that increases that pulmonary blood flow. And with increasing that pulmonary blood flow, then that makes that child more prone to pulmonary edema and congestive heart failure. One of the obstructive defects is coarctation of the aorta, and what you can see in this picture is that we have a narrowing of the aorta right off of the aortic arch. And so what happens with that is that the heart has to contract harder to get the blood past that obstruction, but also the blood tends to kind of back up. So if it's backing up into the lungs, and so then they're more prone to get pulmonary edema. Also, with decreased pulmonary blood flow defects, the primary one that we're looking at is tetralogy of flow, which is actually 4 defects. And those 4 defects are pulmonary stenosis, so you can see that narrowing of the pulmonary valve. We have right ventricular hypertrophy. So if you think about it, if you have a narrowing or a stenosis in the pulmonary valve and you're trying to push blood up into the pulmonary valve, eventually that muscle is going to build up in the same way that when we work out in the gym, our muscles build up. So instead of the right side being the weaker side of the heart, in a child with tetralogy, the right side is very muscular. We also have a ventricular septal defect, and that is causing mixed blood, the mixing of the blood going from the right side to the left side. And in this case, it means that that mixed blood is what's going out to the body. In addition, we have an overriding aorta, and that causes its own little deep problems. One of the things that we see happening with kids with tetralogy is they get something called a tet spell. And it often happens when they start getting upset. So during crying or during a feeding, because with feeding, you've got to coordinate breathing, swallowing, and taking a breath. And if you don't have those coordinated, you'll choke and sputter, aspirate, all those kind of good things. So these kids, it's not that they have a discoordination with it, but it tires them out. And as they get tired out, they're expending more energy in order to take their feeding, and it starts getting them upset. And they start crying, and they get this very pale bluish skin during these times, and they get hypoxic, and potentially these tet spells can be lethal because they're very unpredictable, and they can occur in even the patients that don't have a lot of cyanosis with their tetralogy. The mechanism is thought to include a spasm of that septum that acutely worsens the right ventricular outflow tract obstruction. So in other words, what they're saying is that the right pulmonary vein, artery, I'm sorry, that pulmonary artery is becoming more constricted during this TET spell. And so when these kids have that happen, that means that you're going to have more of that deoxygenated blood go out into the circulatory system, and that's what's causing the cyanosis. So one of the ways that these kids deal with it, and they don't deal well with it as infants, but once they become toddlers or young kids, they will squat. And the squatting is a compensatory mechanism. It's also diagnostic. So most of these kids are getting caught in infancy, but in underdeveloped areas of the world, you could go out and see a kid go into a TET spell and go, he's having a TET spell. And that would tell you that that kid needs to have heart surgery. So the characteristic of this is that the older children with tetralogy of Fallot increase their pulmonary blood flow by squatting. And the squatting increases peripheral vascular resistance. So if you think about it, the blood can't return as easily, and that decreases the right to left shunt across the VSD, and that allows that spasm to relax so that more blood ends up in their lungs and they become more oxygenated again. So yes, these kids do eventually have heart surgery on that, on their defects, and they can live a long life after their surgeries. The mixed defects, which are transposition of the great vessels and a hypoplastic heart syndrome, there is right hypoplastic heart syndrome, but most people are more aware of the left hypoplastic heart syndrome. And you can see here in the picture of the left hypoplastic heart is that the ventricle does not develop into the nice big space that it should be. And so even though it's functional, it doesn't hold enough volume to provide oxygenation to the body. The other thing that happens is that their ascending aorta is also small, and so they really are not getting the blood flow out to the body. So the right side of the heart tends to be enlarged. They tend to have a PDA, and that is something that they're dependent on. And it used to be with these kids is that nobody would catch them until they had gone home. And at about age 5 to 7 days, when that PDA was really closing down on them, they would start turning massively blue. And if their parents didn't notice it right away, these kids would die at home, and they would have no idea why they died until they did the autopsy and found out that they had a hypoplastic left heart syndrome. Now we do tests on these kids before they go home because they literally look like nothing's wrong with them as long as that PDA stays open. And so we now test them because if you check their oxygenation in their right hand and their left foot, which we tend to do it that way, don't ask me why, because either one of the feet would work. But when you do that, you will find more than a 20% difference in their oxygenation between their right hand and their lower extremity. So we catch a lot of these kids before they go home now, and we're able to start treatment with them. There's several ways that we treat them until Surgery, we put them on prostaglandins, which are enable the patent ductus arteriosus to stay open. And then once surgery is completed, they do a number of things that help to make that single ventricle function a little better. They give them mixed blood so that they are able to oxygenate to some level. There's two different ways of treating them. One is that they can have a complete heart transplant, and Dr. Bailey started doing those with infants back in the 80s. And I happened to be out at Loma Linda when Dr. Bailey started doing his heart transplants on infants. And I was there when he thought that they might be able to use a baboon heart on an infant until they got a little bit older, because there's more organs available for older children than there are for infants. And there were a lot of problems that happened related to that transplant that he did. And if you ever want to find out, I will tell you, but I'm not putting it out for public consumption. As far as the transposition of the great vessels, we talked a little bit about this earlier, how the pulmonary artery comes off of the left ventricle and the aorta comes off the right ventricle. So basically we're taking blue blood out into the body and oxygenated blood back to the lungs, and we just keep recirculating this oxygenated blood back to the lungs. So they tend to have pulmonary edema and congestive heart failure, and they're blue. And this is one of the cases where the doctors will do interventional heart caths to enlarge that foramen ovale so that there's mixing of the blood until they can do surgery on these kids. And then it's open heart surgery for these repairs. When we look at congestive heart failure in children, it's usually due to impaired myocardial function. So what we see is tachycardia, fatigue, weakness, restlessness because they're having difficulty breathing and oxygenating. They're often pale, they have cool extremities, they have decreased blood pressure and usually decreased urinary output because we're sending more blood to the lungs and we're not getting enough pressure to the kidneys. They have pulmonary congestion, so they have tachypnea, dyspnea, respiratory distress, and exercise intolerance and cyanosis. They also have systemic venous congestion, so we see both peripheral and periorbital edema, dramatic weight gain. So kids that we suspect are at risk for congestive heart failure, we're going to weigh them daily. They may have ascites and hepatomegaly, so their liver is enlarged, and I've seen some livers get really huge. And they may have neck vein distension. So if we don't do something about it, they can go into heart failure. So some of the things that we want to do is to promote oxygenation. And we do that by positioning them with their head up at a 45-degree angle. And in infants that have ductal dependent lesions, meaning that if that PDA closes, they're not going to get the mixing of the blood that they need to maintain the little bit of oxygenation that they have. They may begin IV prostaglandin E. And if they have absent femoral pulses or the inability to increase their systemic PaO2, they will give them with some oxygen. It's suggestive of a ductal dependent lesion. And we want to support cardiac function. So we do that by reducing their preload. So we may give them diuretics. Normally, we will give them Lasix or furosemide. And just remember, though, that if we're having to give them furosemide, it is a potassium wasting antibiotic. So they may need to have potassium supplementation. And if they show that they need them long term, we may give them aldosterone antagonists because those are potassium sparing diuretics like spirolactolone. But if the child is on both an ACE inhibitor and spirolactolone, they could have hyperkalemia. So needless to say, we're going to have to, if they're on diuretics of either type, and especially if they're also on an ACE inhibitor for blood pressure, we may need to very closely watch their electrolyte levels, especially their potassium level and their sodium levels. We'll also want to improve their contractility, and we can improve their contractility with IV inotropes like dopamine, dobutamine, amiodarone, or milorone. Another way of improving their contractility is by starting them on digoxin. And it's often started or adjusted when we see signs of heart failure in children. Afterload is reduced by giving ACE inhibitors or beta blockers. And so we want to decrease the constriction of the vessels or the resistance by giving them these medications. Some of the older children may require placement of central venous or pulmonary artery catheters in order to monitor their venous pressure and their cardiac output during stabilization. But we have to make sure that we rule out anemia as well. We look really bad if we start doing all of these interventions and all they really needed was some blood. So we always make sure that we do a CBC as well, looking at their hematocrit and their hemoglobin. Nutritionally, they need to have high calorie, low volume, especially when they're infants. So you often see these kids on 24, 25, and even 27 calorie per ounce formula. So you could expect that I might ask you a question that would be something to the effect of, if a child is eating every 3 hours a certain volume of 27 calorie per ounce formula, how many calories are they getting in a day? Or I might even add that they have a certain weight, and so how many calories per kilo per day are they getting? Because these are all calculations that pediatric nurses would do with these children. And then, of course, we want to promote rest. So we want to make sure that they're in a low stimulation environment, but yet if they're older children, that they are allowed to do whatever they feel they are capable of doing. Unlike adults who will try to do things that they shouldn't do even though they don't feel well, when a child doesn't feel good, they lay down and sleep. And they don't keep running around and playing when they're sick and when they're not feeling well. And in this case, not feeling well because their heart isn't functioning well. And so in many cases with children, we allow them to tell us when they need to rest. And children with heart defects still need to be treated like children and still allowed time to play even though that play may be quiet play or not as rambunctious as the average child. Some of the surgical interventions include open heart surgery. There's also some closed heart procedures that can be done to open up those obstructions with by ballooning them open. Often, like with the hypoplastic left heart procedures, they either get a full transplant or they have a staged procedure where they get one procedure and maybe a year or 2 years later they get another procedure, and maybe a year or two they get a third procedure, and basically what they're trying to get them to the point where they are able to qualify and be able to get a transplant. And so in all of these situations, we need to prepare the child and the family for what's ahead of them and what they can expect before the surgery, during the procedure, and in the recovery period after the surgery, and what will happen when they go home after they have recovered. There is something known as post-pericardiotomy syndrome, and in this syndrome, the symptoms are fever, a pericardial friction rub, which means that the heart is rubbing on the pericardium inside, and pericardial and pleural effusions. So as it rubs, it is causing increased fluid to build up, because none of our parts of our body want to have rubbing go on. And it occurs in the immediate post-operative period. It can also occur later, as late as post-operative day 7 to 21. So it's kind of like just as people start thinking that their kid is out of the woods, they can develop this post-pericardiotomy syndrome. The cause is unknown. If they knew, they would stop it, but there's several theories. One is that there may be a viral infection that causes it. Another is that they may have an autoimmune response to the trauma of the surgery. There may be a reaction to the blood in the pericardium, because they can't get every last little bit of blood out of the pericardium in an open heart surgery situation. And it may, with that pericardial or pleural effusion, it may require a pericardiocentesis or a pleurocentesis. So in other words, either they're going to inject or insert a needle into that area and pull that fluid off, or with the pleurocentesis, they may need to actually have a chest tube to allow for drainage of that fluid. So let's talk about some of these acquired cardiovascular disorders, some of the infections and inflammatory disorders. Infective endocarditis is a microbial infection of the endothelial surfaces of the heart's chambers, the septum, or the valves. Congenital heart defects of the septum or the valves, or if a prosthetic valve has been put in, increases the child's risk of acquiring bacterial endocarditis, which is potentially fatal. The most common causative agents are strep viridans or staph aureus. And in some cases, they may get a fungal infection such as Candida albicans. And we see this, the candidal infections, often in children that have been on long-term antibiotics for various infections or for prophylactic treatments. The diagnostic tests are a blood culture, and the blood culture is going to be looking for bacteria and or fungus, doing a CBC, which would show anemia and leukocytosis. Urinalysis may show microscopic hematuria, and an echocardiogram will show cardiomegaly, possibly abnormal valve function, and areas of vegetation. So if you look at this picture on the right, you can see this sort of abnormal bumpiness compared to the valve on the right side, and that's a vegetation. And literally, when you're doing the echocardiogram, it kind of moves with the blood flow, so it looks like leaves flowing in the blood, almost like leaves in the wind. And so that's why they call them vegetations. So the treatment for this is to treat whatever the offending organism is, whether it's a bacterial or a fungus, and kill it off. In the case of vegetation, sometimes they have to go in and do interventional catheterization to remove that vegetation so that it doesn't break off and cause an emboli. Rheumatic fever and rheumatic heart disease. The rheumatic fever is an inflammatory disease that occurs after a group A beta hemolytic strep pharyngitis. So in other words, group A strep. And it's infrequently seen in the United States, but it is a big problem in developing countries. Rheumatic fever is usually self-limiting, but it does affect the joints, the skin, the brain, the serous surfaces, and the heart. Rheumatic heart disease is the most common complication of rheumatic fever. And so what normally happens is that there's been damage to the valves as a result of the rheumatic fever. So the clinical manifestations is done by the Jones criteria. And in the Jones criteria, you need the presence of 2 major manifestations or 1 major and 2 minor manifestations. In more than half the cases, the rheumatic fever scars the valves of the hearts and forces the heart to work harder to pump the blood. Over a period of months or even years, the disease can strike again, and it can damage the heart even further, leading to a condition known as rheumatic heart disease, which can eventually cause the heart to fail. So rheumatic fever can also cause a temporary nervous system disorder that was once known as St. Vitus dance. It's now known as Sydenham's chorea. And this is a nervous disorder that's characterized by rapid, jerky, involuntary movements of the body that usually occurs more on one side of the body. And people with mild cases of chorea may find it difficult to concentrate or to write. And in more severe cases, it can cause the muscles of the arms, the legs, and the face to twitch uncontrollably. It can also be associated with muscle weakness and emotional outbursts. So, going back to this Jones criteria, we have carditis, polyarthritis, so arthritis in more than just one joint, erythema marginatum, subcutaneous nodules, and chorea. So when we look at acute rheumatic fever, we often see a delayed sequelae of group A strep pharyngeal infections. And the diagnosis is based on the modified Jones-Caffey-Powell criteria. So if you look at this, the J is for joints, so your polyarthritis. O, they look like a heart patient. N, they have subcutaneous nodules. E, they have the erythema marginatum. And S, they have the Sydenham chorea. The cafe part is that C is for the CRP is increased. A is for arthralgia, or pain in the joints. F is for fever. And E is for an elevated ESR. So when we look at the CRP can actually be as high as 26, and we really should be looking at a CRP normally of less than 1 in most cases. And let's see, I thought I had something here about the ESR, but I'm not seeing it here. The PAL portion of it, we have a prolonged PR interval that's related to the effects of the inflammation and the scarring on the valves. We can have an anamnesia of rheumatism. So in other words, we have rheumatic pains of the body, and then the leukocytosis. So when we look at it, we have, well, let's make this person be quiet for a minute, but we have a child that looks like this, that has this unusual rash, and that's the erythema marginatum that we're talking about. And I think I've shown you this video about the chorea, so I'm not going to show it for very long, but I just want to remind you what that Sydenham's chorea looks like. Whoops. Let's bring her back and get her.
Hi, I'm Callie.
And see how her shoulders are moving.
And on January 1st, 2011, I was diagnosed with Sydenham's chorea. And that is the reason why I look like I'm dancing right now. It's been almost a year, and this is just a flare-up. I guess I mainly don't shake now. But it's pretty distracting, as you can tell.
So you get the idea of what the chorea looks like, and that's why they used to call it St. Vitus dance. The treatment for rheumatic heart disease is prevention of the group B strep pharyngitis, or the strep throat. And when you are diagnosed with strep throat, that you get your treatment, either penicillin G, given intramuscularly just one time, you don't need it multiple times, or penicillin V by mouth for 10 days, or sulfa by mouth for 10 days. If you're allergic to penicillin, then sulfa can be given. Or if you're allergic to penicillin and sulfa, you can get erythromycin by mouth also for 10 days. Also, you want to make sure that if the person is having recurrent rheumatic fever, that they get the same type of treatment, either the penicillin G, the penicillin V, or the sulfa by mouth, or the erythromycin. The remainder of the treatment includes rest to help your body to recover, aspirin or other NSAIDs for pain and fever. Again, this is not a viral infection, which is why they can take aspirin. Otherwise, we would not give aspirin for a viral infection to a child because of the risk of the other disorders. And long term, they're going to need antibiotics prior to any dental or surgical procedure. And if it's severe, they may need a heart valve replacement to prevent heart failure. The other thing I wanted to mention when we're talking about rest here is that if a patient is admitted with rheumatic heart disease or even rheumatic fever, but we're more worried about it when we have rheumatic heart disease because we already have scarring of the heart. Rest is especially important, and so these kids are not allowed to go running around or going to the playroom. They literally have to stay in bed, because if they go running around and acting like kids because they really don't feel bad, or at least they don't feel like they feel bad, they risk having additional damage to their heart. And so in this case, we would not allow these kids just to do whatever they wanted to do, because the infection has damaged their heart, and the additional infection can continue to cause more damage to the heart. Kawasaki's disease is also known as mucocutaneous lymph node syndrome. It's an acute systemic vasculitis of unknown cause. In 75% of the cases, the child is younger than 5 years of age, and it comes up in 3 phases. The acute phase, they get a sudden high fever that's unresponsive to antipyretics and antibiotics. In the subacute phase, it lasts from the end of the fever through the end of all of the Kawasaki disease clinical signs. And then in the convalescent phase, the clinical signs have resolved, but if you look at their lab values, they haven't returned to normal. And the convalescent phase ends when the normal values have returned to normal in about 6 to 8 weeks. So the diagnostic criteria for Kawasaki's, it requires more than 5 days of fever plus more than or 4 or more of the following criteria: bilateral bulbar conjunctival injection. So in other words, you can see that the eye is red. The conjunctiva is red on it. The oral mucosal changes, including injected or fissured lips, an injected fissure, and this strawberry tongue. So if you look at their tongue, it looks like a strawberry. You can almost imagine the seeds on the strawberry with the way that tongue looks, and you can also see how their lips are all fissured. Peripheral extremity changes, including erythema of the palms and the soles, edema of the hands and feet in the acute phase, and perlungal. A polymorphous rash, so you can see this kid has this rash all over, and cervical lymphadenopathy, meaning that you have 1 or more lymph nodes that are greater than 1.5 centimeters in diameter. So basically, they look like they have the mumps. So the treatment and the follow-up of Kawasaki's disease is to give them aspirin. And so you may say, well, wait a minute. We're not supposed to give kids aspirins, but this is one disease where we give them aspirin. And so they get 80 to 100 milligrams per kilo per day for fever. And then, even after the fever is gone, they get 3 to 5 milligrams per kilo per day as an antiplatelet dose, so that they don't build up increased platelets. They're also given intravenous immunoglobulin. And their long-term outcome, most recover without any problems, but they need to have cardiac follow-up to rule out coronary artery damage. So unfortunately, we have some children who also have systemic hypertension. Essential hypertension has no cause. The secondary hypertension usually has an identifiable cause, like an infection or something like that. Pediatric hypertension is generally secondary to a structural abnormality or an underlying pathologic condition like renal disease, cardiovascular disease, endocrine or neurologic disorders, or drug abuse. And we see the drug abuse in older children. So with the hypertension, we want to identify kids that are at risk and treat it early. The treatment initially is to go non-pharmacologic with weight reduction, exercise, potassium supplementation, low-fat diets, and or a low-sodium diet, and sleep studies to make sure that they don't have sleep apnea, because just like with adults, many cases of hypertension is caused by sleep apnea and that hypoxia that occurs as part of the sleep apnea. Pharmacologic treatment includes beta blockers. So usually we start with the angiotensin converting enzymes inhibitors, the ACE inhibitors, but as you know, there are side effects that are associated with those, such as that dry cough. And so often they are put on the angiotensin receptor blockers, the calcium channel blockers, and often diuretics are added as well. And then they're monitored for a very long time. One thing I do want to mention, because I mentioned it in the earlier slide, is that one of the illicit drugs that's known to cause hypertension is cocaine. And so if we have a child who is experimenting with illicit drugs and are on some form of cocaine, then we may see increased blood pressures on that child. So basically getting them off of their cocaine is going to be the cure, but potentially could be having other problems related to the damage that existed because of their cocaine use. And again, unfortunately, we're starting to see more and more younger children with hyperlipidemia. The treatment is lifestyle modification, restrict the intake of cholesterol and fats to no more than 300 milligrams per day, restrict the intake of refined sugar. They really are, if you read the literature, which a lot of the doctors aren't reading the literature because it's so much easier to give you drugs than to treat with lifestyle modification. But if somebody goes off their refined sugar and refined foods, their lipidemia tends to drop, whether it's a child or an adult. And they really are starting to feel that the lipidemia has more of a problem with refined sugars and starches than the cholesterol and fat intake. It's one of those things that it doesn't seem logical. It seems more logical that if you don't eat the cholesterol containing foods, that's going to take care of it. But your body makes cholesterol, all of it, on its own. And they actually are finding that the sugars and refined starches have more to do with increases your lipidemia than the cholesterol and fats in your diet. Exercise, increase intake of whole grains. Make sure that there's 60 minutes a day, 5 days a week of exercise. If it's an adult or an older child that started smoking, get them to stop it and avoid secondhand smoke. And that's something that is where the whole family has to make a commitment to that so that the child isn't in that secondhand smoke either. If there's no response to diet changes or medication, they may start cholestyramine or cholestyramine, which is Questran, to help with the hyperlipidemia. Or they may actually start them. We're not seeing so much of the other lipid-reducing medications used on children because there hasn't been a lot of research as far as how kids will respond to those. So we've talked a lot about the different things that can happen besides the anatomical changes, but children or parents need to have education as far as cardiac surgery if a child requires cardiac surgery. And so some of their teaching is the heart anatomy and its function. And I know that this may seem like one of those things that the doctors ought to be talking about to their patients, but often the doctors have nurses that are expert cardiology nurses, and the nurse goes out to do the education of the patient, and then the doctor comes along and gets the consent. So basically, all of these things like the anatomy and its function and the blood flow through the heart, all of those things are things that as nurses we should know and be able to teach to parents. Also, they'll be taught the events that will happen before surgery as far as the tests and the preoperative care, all of the stuff that goes along with that. They'll be shown the location of the child after the surgery and what the child's going to look like after surgery. There is nothing scarier for a parent than to walk in and see this intubated child with leads and stuff all over their bodies and various venous and arterial catheters coming out of their neck and their hands, and it's a scary thing for them to walk into. So showing them what to expect ahead of time helps them not have to deal with that shock. Also, the locations of the incision and how it will be covered with dressings and what postoperative activity levels that they can expect. They'll also get education as far as nutritional restrictions and the medications, how to give them, all of those things. Preoperatively, the assessments that we do are a temperature and weight measurements, examination of the extremities for peripheral edema, for clubbing, and evaluation of the peripheral pulses. We auscultate the heart for the rate, rhythm, heart sounds, murmurs, any clicks or rubs, and do a respiratory assessment that includes the respiratory rate, the work of breathing, and auscultate the lungs for breath sounds. The other things that we really have to think about when we're thinking about cardiac surgery is, are there any signs or symptoms of any infection? Because we don't like to do surgery like this on a child that may have an infection brewing. If this child's going to have a heart transplant, then we're also going to do chest x-rays, electrocardiograms, echocardiograms, exercise stress tests, cardiac catheterizations, pulmonary functions tests, and then blood work like a CBC with diff, their prothrombin and partial thromboplastin times, serum chemistries and electrolytes, blood urea nitrogens and creatinine, making sure that their kidneys are working okay. We're going to be looking at urinalysis and urine creatinine clearance because they may not have been getting good blood flow to the kidneys up to this point, and we want to know what their kidney function is at this point. And definitely we're going to do blood, throat, urine, stool, and sputum cultures for bacteria, viruses, fungi, and parasites, because when it comes to a heart transplant, we are not doing a heart transplant on somebody who's infected, because that heart being in a healing mode is the first thing to get infected. So we're going to make sure that this kid is not infected in any way, shape, or form. In addition, we're going to be checking them for Epstein-Barr virus, cytomegalovirus, varicella herpes, hepatitis, and HIV titers, because they may have gotten blood, and so they may have gotten tainted blood, and we just didn't know it. HLA typing and panel reactive antibody typing and titers, computerized tomography or an MRI scan, and electroencephalogram. We want to make sure their brain is okay before surgery, so that if something happens and they throw some kind of a clot and get a stroke after surgery, we know when it happened. that we're not looking at an old problem and thinking that it's a new one. They will also do consults with neurology, psychology, genetics, social work, nutritionists, the physical and occupational therapists, financial coordinators, and the case manager, because these are kids that are getting heart transplants, or anyone that gets heart transplant. This is not an inexpensive thing to do. And so we want to make sure that everything is taken into consideration. And psychologically, how are they going to deal with having someone else's heart beating inside of their chest? There's a number of different types of heart transplant. There's the orthopic transplant, the heterotopic, where it's sort of a piggybacked onto basically the diseased or abnormal part of the heart is removed, and only the part that needed to be replaced is replaced. There's a number of organ donor issues because we have to make sure that there's a good match so that this heart is able to function as long as possible. And the nursing considerations include all of the things like blood pressure, the need for inotropes, the need for extensive monitoring as far as heart function goes. And I'm not going to go into all of those things because you're going to be talking about more of those kinds of things when you get into your ICU nursing in MedSurg 4. Some of the things that kind of go along with this chapter includes things like SIDS. And SIDS is sudden infant death syndrome. They really don't know the cause of it. The incidence is about 50.4 per 100,000 live births, so it's a fairly common thing that happens. It's most common at age 2 to 3 months, and the incidence greatly decreases after 9 months of age. Usually we will tell parents, because they're so worried about whether or not SIDS could happen to their child, that when that child gets to be 9 months, you can take a deep breath, because usually it doesn't happen after that point. Risk factors for SIDS include maternal smoking, sleeping in a proned position, and soft bedding. So it's why the recommendation from the AAP is that they have a firm mattress and that they sleep on their backs. The infant risk factors include low birth weight or a preterm birth, low APGAR scores, recent viral infections, a sibling of 2 or more SIDS victims. In other words, if your older sibling died of SIDS, your risk factor of having SIDS is greatly increased. Tends to be more males than females, and also more American Indians, Native Indians, and African American ethnicities are more at risk for SIDS. The American Academy of Pediatrics Back to Sleep campaign has reduced the risk of SIDS by recommending that infants sleep in a supine position while sleeping. So when a child is laying on their back, the airway is anterior. So a lot of people have this fear that if a child is laying on their back and they throw up, they're going to aspirate. But if you think anatomically, if somebody throws up, it's more likely to go back down the esophagus, because the esophagus sits closer to the back and the airway sits above the esophagus. And so it's harder to aspirate when you're laying on your back than when you lay on your stomach. And so most people think that they're safer if they're laying prone, but in actuality, it would be easier to aspirate when you're laying prone than when you're laying on your back. Also, we remove all pillows, blankets, and any moldable mattresses from the bed, and toys, because young infants are not good at removing those things or getting themselves untangled from blankets. And any of you that have small children that have bothered to leave a blanket in, it's not unusual to walk in and see a kid almost tied up in their blanket in their lower extremities. Well, that can happen around their face as well. Also, we want to encourage breastfeeding because we have found that the incidence of SIDS is lower in breastfeeding infants. As far as the nursing role with SIDS prevention, obviously education about prenatal risk factors like smoking, the Back to Sleep program, and avoidance of soft bedding, toys in the bed, or blankets in the bed. We want to care for the family after the SIDS, after the child's death. Some of the issues that are involved with that is that this has happened so suddenly and it was unexpected and it can't be explained. And so, like many parents say, the parent isn't supposed to live past their child. The child's supposed to live longer than the parent. And so having to mourn a child, and especially an infant, that has so many more years to live is very daunting for any person. And many people say they think that they're being sympathetic, but they're actually saying things that make the mourning more difficult. And they think that because the child didn't live very long, that the mourning shouldn't last very long. But that child is loved just as much as somebody who's been there for 80 years. Autopsy is kind of a sensitive subject. Some parents want an autopsy because they want to know if there's some answer to why their child died. But, and definitely if there's any kind of inkling that there could be something other than SIDS involved in this child's death, an autopsy may be requested. One thing that some parents find comfort in is that even though they may not find anything on autopsy, it may give more information to research about how to prevent SIDS in the future. You want to make sure that you provide family-centered bereavement care. Make sure that they are allowed to hold that baby as long as they want. And have professional grief counseling soon after the event. Usually they try to get somebody introduced to the family, and that person will say, I'm going to be calling you in a few days, in a couple weeks, and they usually follow up with these families for quite a while. Also, we want to refer them to SIDS groups because nobody understands what they've gone through like somebody who had a child with SIDS. We also have something called apparent life-threatening events, or an ALTA events. It's also known as a near miss SIDS, or a near miss event. In other words, this kid was pretty much dead and somehow they managed to get him back alive. I wanted to mention that with SIDS, it doesn't matter how good your CPR is, you will not bring this kid back. And even if you had shocks available, you would not get this kid back because there is something going on that they just do not respond to resuscitation. So really the name of a near miss SIDS is a misnomer because there is no such thing as near missed SIDS. It either is SIDS or it's a life-threatening event. The infant experiencing an ALTA may experience apnea. They may have a change in color, in muscle tone. Often it's associated with gagging or coughing. And the ALTA requires significant intervention. The infants that experience an ALTA are discharged home, usually with home apnea monitors, but they are at 3 to 5 times higher risk for a SIDS event after they've experienced an ALTA event. Parents are taught how to do CPR before these children are discharged home. The Alta diagnostic workup and diagnosis is based on a detailed description of the event. They look at the prenatal and postnatal history, and the diagnoses often include things like neurologic events like seizures, GI problems like reflux, respiratory problems, or cardiac conditions. They may have ENT abnormalities that have caused them to not breathe easily. They may have had an ingestion of a medication or of a poison, and so those have to be ruled out. And also we've got the problem of Munchausen syndrome by proxy, where the parents actually in some cases cause these events to happen. We've actually seen things in the past where they recorded the room where the mother and child were, and actually saw the mother put a pillow over the face of their child and cause their child to code. These people are mentally ill, and then of course we have to rule out just out and out child abuse as well. Kind of related to that is apnea of infancy or apnea of prematurity. It's pathologic apneas in infants. In this particular case, we're talking about infants that are more than 37 weeks of gestation. Apnea of prematurity is actually apnea that occurs because of an immaturity in the center of the brain that tells us to take our next breath. The clinical presentation of apnea of infancy looks like an Alta experience, and the therapeutic management is to give either theophylline or caffeine. And I think I told you guys when you were in pharmacology that we used to give theophylline to premature babies to make that center that respiratory center more sensitive to the increasing CO2 levels so that they would take that next breath. Well, what we discovered was that there were a lot of byproducts of the breakdown of theophylline, but the byproduct that was actually improving their respiratory drive was caffeine, because theophylline breaks down into caffeine and many other chemical substances. And the other substances cause more side effects than the caffeine all by itself. So now we tend to give caffeine as the drug of choice for apnea. They're often put on home apnea monitors. They need to have good family support, and they definitely receive CPR training before they are going home. This picture off to the side shows a home apnea monitor, and basically what they are is like a little belt, a very soft belt that goes around the chest, and the leads are placed on either side under the arm. And so you just have two leads that go to the monitor, and then the monitor alarms whenever the child doesn't sense that breathing. Usually we tell parents that although it seems like this is something that you would want to have, this is not a fun machine, because if the leads don't pick up and things happen, you get a lot of false alarms and get woke up in the middle of the night thinking that, oh no, my baby's not breathing, and you get in and the kid is perfectly fine. So they need to have that family support of knowing that they're going to have a lot of disrupted sleep that is beyond what you deal with just with a newborn. Just a reminder, with children, we tend to have more airway problems than cardiac problems. We don't tend to have myocardial infarctions with children. We tend to have respiratory failure with children that leads to cardiac failure. So the whole airway breathing and circulation is extremely important in children, even though we've kind of changed that order in adults. We want some of the ways that we maintain an open airway for ventilating kids is to make sure that we have the head in we call it a sniffing position. So if you look at this first picture, if the chin is allowed to come down, the airway blocks off. But if you raise that chin up again into that sniffing position, almost like they're trying to smell what perfume you've got on, it will open up that airway. And one way to help keep the head in that position is to put a small towel or blanket under the neck, and that will help to keep them in that sniffing position. We can also do a jaw thrust, and that will also help in older children. This towel or washcloth or blanket under the neck is something that we do on young children and infants. Some of the airway and ventilation methods, we have the anesthesia bag or the flow inflating ventilation system. In these situations, you have to have a oxygen source or a gas source in order for that bag to inflate. And you often see this on television programs because it's just so much more dramatic than these bag valve mask devices. And these, we actually have manual resuscitators as well that go along with that. The laryngeal mask airway actually is a small soft mask that is able to be put down in the back of the throat and allows for ventilation without intubation and is a more stable way of ventilating than the bag mask devices. Tracheal intubation is when we actually insert an endotracheal tube into the trachea, allowing the child or adult to be artificially ventilated. One of the things that we have to think about is rapid sequence intubation medications, and these are medications like atropine that will dry the secretions and prevent bradycardia from the vagal stimulation. It usually is given prior to the placement of the endotracheal tube. It can also include a paralytic agent or a hypnotic or analgesic like fentanyl, and they're usually given IV so that the child or the adult don't remember or feel the intubation procedure. So question, the nurse is assisting a child in respiratory distress and inserts a rubber connecting tube of an inflatable silicone mask blindly into the airway to form a seal. What method of resuscitation is being performed by the nurse? Anesthesia bag, flow inflating ventilation system, bag valve mask device, or laryngeal mask airway. So what they're describing is the laryngeal mask airway. It is this laryngeal mask, and using this method, the nurse inserts the rubber connecting tube, which is this little area over here on the right. It's usually a silicone tube, blindly into the airway or over the airway to form a seal. And so the others are obviously not this rubberized or synthetic device. We don't use latex with children because they have so many opportunities to be overexposed to latex and develop latex allergies, especially if they have may require numerous surgeries over their lives. PALS has a mnemonic of DOPE for troubleshooting the status of an intubated child. D is for displacement. And so if you have a child that is intubated, you want to make sure that that tube is still where it needs to be in the trachea. O is for obstruction, that the tube is obstructed, like with a mucus plug. You're not going to be able to bag tube ventilate this child. Pneumothorax is usually a result of a sudden change in the child's assessment, like after we give them surfactant. We see a sudden change in their lung compliance, and that can cause a pneumothorax. Equipment failure. Is there a disconnected oxygen supply, a leak in the ventilator circuit, or a loss of power? When we look at those rapid some of the drugs that we may need to give in an emergency situation through a tube, if we don't have IV access, the mnemonic LEAN, LEAN, can help you to remember the medications that are able to be given through an endotracheal tube to be absorbed in the lungs and will be absorbed into the blood system through the lungs. Lidocaine, L is for lidocaine, and so those are definitely that's definitely one drug that can be given. Epinephrine can be given through the tracheal tube. Atropine and naloxone. These four medications can be given down the tube, and usually the dose needs to be increased to deal with the lower and slower absorption than would be accomplished if you gave it through an IV dose. So epinephrine, we usually double or triple the dose given through the endotracheal tube compared to what we would give in an IV solution. But if you have no IV access and you are coding a child, these are the four drugs that can be given through that endotracheal tube. Better that you save a child than keep trying to stick them for an IV. At least you will have gotten these drugs in to try to bring up their heart rate. Anaphylaxis. The definition is acute clinical syndrome resulting from the interaction of an allergen and a patient who is hypersensitive to that allergen. This is often life-threatening. The early manifestations are an uneasiness, a restlessness, irritability, severe anxiety, headache, dizziness, paresthesias, disorientation, and unconsciousness. Later in the clinical situation, they may have angioedema of the eyelids, the lips, the tongue, the hands, the feet, and the genitalia. So in other words, we have swelling of all these areas. So think about some of the pictures you've seen of people that have overwhelming allergic reactions to bee stings or something like that, or eating shellfish. Later symptoms include bronchiolar constriction, pulmonary edema, hemorrhage, laryngeal edema with severe upper airway obstruction. This is a medical emergency when you're at this point. Shock caused by mediator-induced vasodilation, capillary permeability, and the loss of intravascular fluids into the interstitial spaces. So in other words, all that swelling that you're seeing, that angioedema, has taken the volume out of the intravascular space and has put it out into the interstitial space. This is going to result in hypotension and impaired cardiac output. So if we look at this, an acute IgE-mediated response to an allergen involves many organ systems, and it can be life-threatening. It usually starts within 5 to 10 minutes of an exposure. And so what we get is histamines and secondary mediators are released from mast cells and eosinophils. Think back to all this stuff that we learned back in patho. Then we get cutaneous and cardiopulmonary, gastrointestinal, and neurologic symptoms start up. And then we get vasodilation, resulting in rapid decrease in plasma volume, leading to the risk of circulatory collapse. Finally, they may need prolonged resuscitation, including volume. And if we can't stop it at that point, death will result. Therapeutic management is dependent on rapid recognition and in the institution of treatment. The goal is to provide ventilation and restore adequate circulation and prevent further exposure. In mild situations, we may give diphenhydramine, which is Benadryl, and if that's not working, we may need to give epinephrine. If a bronchospasm is present, so I want you to consider that there's two situations going on here. There's one situation where epinephrine is the drug of choice. There's another situation where if we have bronchospasm happening, albuterol is the drug of choice, because we may actually have both of those things happening at the same time. So your patient may need inhaled albuterol and epinephrine for their circulatory collapse. If they have moderate or severe anaphylaxis, we need to establish an airway. Epinephrine by any route that works. So if we've got a tube down, we can put it down that way. If we don't have an IV in yet, we need to give fluids. So we're going to be giving boluses to get intravascular fluid volume up, and we may need to have vasopressors as well. As far as the nursing considerations, prevention is the best thing. So if someone gets exposed to their allergen, having an EpiPen or other needed medications are necessary. Wearing a medical ID so that others are aware if they should have a collapse. Make sure you have the head in an elevated position to increase oxygenation. Make sure that you've called emergency medical services and that you've started CPR if that's required. Getting an IV in to get intravascular fluids going is very important, and emergency medications given IV if possible. We're going to definitely monitor vital signs and urinary output, because that's going to tell us whether we're getting good circulation and blood pressure to the kidneys. Somewhat related is shock. And again, I'm not going to spend a lot of time with these because you're going to be covering them ad nauseum in your MedSurg 4 course. So on your box on page 782, there's definitions of systemic inflammatory response syndrome, which would be SIRS or SIRS, which somehow got off my page. Shock is the result of dramatic respiratory or hemodynamic compromise. Usually it's because of impaired cardiac output, impaired systemic vascular resistance, or a combination of both that's causing the shock. In infants and young children, it differs from adults in that their cardiac output is dependent on heart rate, not on their stroke volume. So as you remember from patho, there's two ways to increase your cardiac volume output. Either you increase your heart rate or you increase your stroke volume. So if you're increasing your stroke volume, you actually slow down your heart rate so that the ventricles have longer to fill, so that the heart has more to push out. So that increases their stroke volume. And what we know is that initially, even in adults, their heart rate goes up before their stroke volume, before their heart slows down to increase stroke volume. So what we see with infants and small children is they don't do that slowing down to increase their stroke volume. They increase their heart rate. That is a difference between young children and adults. The most common types of shock are hypovolemic, septic, cardiogenic, and distributive. And as you recall, hypovolemic shock is associated with hemorrhage. Obviously, septic shock is associated with an overwhelming inflammation that leads to vasodilation and increased endothelial permeability and activation of the coagulation pathways. And those things cause profound hypotension. Cardiogenic shock is the sudden condition in which the heart is unable to pump enough blood to meet the body's needs. Usually the most common cause for that is an MI. Distributive shock is when you have excessive vasodilation in the smaller blood vessels, resulting in inadequate supply of blood to the body's tissues and organs. So some of the examples of that, actually septic shock, even though we give it its own little thing, pancreatitis and anaphylaxis are all examples of distributive shock. So one specific form of shock that we've started seeing more in the news and deaths caused by it back in the late 70s, early 80s. This was really big news, was toxic shock syndrome. And if you look on box 2316, it'll give you criteria from the CDC as far as diagnostic evaluation. But usually what we see is a history of tampon use where the tampons are not being changed on a regular basis. In other words, usually tampons need to be changed every 2 to 3 to 4 hours. And these are people that are leaving them in for 6, 8, 10, 12 hours at a time. And so what we end up seeing is a infection that develops from this object being in the vagina and being the perfect medium for bacteria to grow in. And so the lab test that we're going to do to evaluate is a blood culture, vaginal and cervical cultures to see which organism is actually causing the infection. The therapeutic management is the same as what we do for other forms of shock, and the nursing consideration is prevention and education on the proper use of tampons. We don't want to scare people to death about them, but we want to make sure that young girls that are starting to use tampons are using them in a responsible manner so that they don't develop toxic shock syndrome. And that pretty much sums up our lecture. Sorry it was so long, and I'll see you all soon.